All right, who's running the show?
You are.
Oh, I don't have enough stripes or bars on my shoulders to run this. We don't have any white shirts here?
We got one hiding.
We got one hiding? Where are we?
It's not really.
Oh, there he is!
T-shirt.
It was dark and I'm getting old and blind. I apologize, Chief. So, well, this is your shop. Anything?
Not that I'm aware of.
Okay.
We can probably catch up later. Has everybody seen the weather for next week?
Yep. 100.
Up to 111 in Spokane, I heard, Monday.
Is there a burn ban?
Burn reception, yeah.
Yes, I get to work down Hoop Fest on Saturday. 106. That's gonna be fun. That's gonna be fun.
A few IVs maybe?
Just probably. Okay. Well, let's get started. I guess the sooner we get started, the sooner we get out, huh? Hopefully today will be interesting. We're going to talk about sports-related injuries. There's a number of different possibilities. Hopefully over the years you've seen a few of these. If you haven't, then hopefully you'll... that one was pretty traumatic. You remember that one?
That was this year.
Last year. This was this year. Remember that one? Took them out for, I guess, just a quarter of the game. They all had to read the rules. Is it okay for him to come back in? All that kind of stuff. It was pretty impressive. It's pretty high up in the air. Yeah. So yeah, as summer picks up, I start to see a few ultimate frisbee players. So that's kind of fun. And we see all kinds of variety of arm and shoulder injuries. So as we look at types of injuries, in sports-related stuff, you'd figure that most of this is due to normally healthy people that are probably trying to push themselves a little too far, or it's just kind of bum luck and something happens. Usually the lesser stuff is simple sprains and strains, but it can get complicated with dislocations, and then even worse, we'll talk about tendon or ligament or even muscle ruptures. That's not a good thing. Fractures are painful, but generally they heal really well, so it's not as bad of an outcome actually as potentially a tendon rupture or a muscle rupture. And then of course, in the summer we get into the water sports that involve put you at risk for asphyxiation or blunt trauma with drowning. And then we'll talk a little about concussion and TBI, which is called traumatic brain injury. So really, if we kind of boil this down, we're talking about muscles and bones and ligaments and the stuff that hook them together. And then over here we've got head injury and potential spinal cord injury as we group these together. It's kind of fun because most of what you see is what you get, as opposed to a lot of the calls you roll on, oh, I'm having stomach pain. You're like, I don't know what that is. So as we talk about pre-hospital care, we'll talk about how to evaluate for these things, looking for types of injuries, how to gauge the severity of injury, because some people may get there, I guess we're not talking about car crashes, but somebody calls you out to a sports complex, or maybe the motocross track over here, and somebody gets thrown off and they're getting up and they're walking it off, and the question is, do they need to be evaluated or don't they? And sometimes they'll make the decision themselves and say, I don't want it, go away. I need to get back on my motocross so I can pay the bills. And so we'll talk about how to treat some of these issues, whether there's nothing obvious or if there is something obvious, and when to really intervene and what level of care is necessary. So like I said, some of these things are just bum luck and accidents But we look at sports injuries, and sometimes it's due to they weren't trained really well, and so they weren't really understanding how to perform the sport. Perhaps they didn't have really good equipment, and so there was an equipment failure. Perhaps there's lack of conditioning. They're trying to do something that they just really aren't ready for. And if you have any question about that, come down and join me this weekend downtown. We'll see lots of opportunities of weekend warriors that think that they've been building up and training, and there will be blood and there will be tears. And then also improper warm-up or stretching that can put you at risk for injuries. So when we talk about sprains, sprains are defined as a partial tear of a ligament. And so a ligament is, think of it kind of like a rubber band that connects two bones together. And if we had the time, if you look at some of these joints, there are multiple ligaments in each joint to try and hold the bones together and isolate the range of motion in one or two particular directions, with a few exceptions. For example, the shoulder. The shoulder can go 360 degrees. It's a pretty impressive joint, and the ligaments are able to support that. But when there's a partial tear or a stretching of that ligament, we call it a sprain, and it's associated with pain and swelling, and sometimes laxity means looseness of the joint. So how many people have played football or basketball and they jammed a finger? Okay? There's no muscles in the fingers. Okay? So really what you did is you sprained one of the ligaments. That finger joint got bent in such a way that the ligaments that hold it together got stretched a little too far, and already it's starting to swelling, it's starting to get tight. The body's natural response to say, don't bend it like that again. Okay? So for example, this is a tear-down view of a few of the ligaments. These are some of the deeper ligaments in the ankle. We've taken away some of the superficial ones. There are a lot because there's a lot of bones down here. And you can see there's all these ligaments that have complex interactions. The foot and the hand are pretty impressive of the complexity to hold these cuboid-shaped marbles together so you and I can walk and run effectively. And so some of these ligaments are the real common ones that can get partially torn or injured. Okay? And here's an example of a sprain. And probably most of you have had this before. It was a partial tear enough that in the next couple of days you started to develop a little bit of blood. Have you had that? How many of you had the blood that goes all the way out here to the toe? Been there, done that. And it really sucks trying to walk because it's bad. What happens is the density of the skin changes right along here because the plantar surface of the foot needs to have that kind of support so it don't puncture your skin with rocks and nails that you walk on. And because it's so thick, gravity drains the blood down, but it can't go past that point, and that's why it'll layer out. It's kind of cool. All right, so sprains, common sites, ankle, knee, wrist. And again, signs include tenderness, pain, sometimes bruising, usually a day later, definitely swelling and inflammation. And as we talked about, decreased movement or range of motion, because the body's saying, hey, it went too far, I don't want it to go any further. Although in the acute phase, you can sometimes get some looseness, and I'll give you some examples of that. Some instability. Oh, here's one. This is called an anterior drawer sign, and it has to do with the knee. And so if you think of the knee at 90 degrees, really you don't want the lower leg to come apart from the upper leg. And so if you bend the knee at 90 degrees and you grab underneath here and you lift out this way and the leg starts to move, you've blown one of the ligaments. It's not supposed to do that. It's called an anterior drawer. So picture you walking up to the drawer in a cabinet and pulling out. And that moves. in a normal human being, you can pull forward and push back and it does not move. In somebody that's had an injury, if you pull forward and it starts to come out, anyone know what ligament has been ruptured?
ACS.
Yes, good call. ACL. That's the anterior cruciate ligament. Skiers get it. Sometimes football players, tennis players, plant and pivot. And it blows that ACL. Yeah, and soccer. Very good. Yes, thank you. And that's how we diagnose it. It's just pulling on it. So all of a sudden that ligament is blown. So that's loose now, and it'll sit there and wobble. The patient doesn't really like it. Feels kind of uncomfortable. And then they look down and they're like, I don't remember that, doing that. So strains pertain to muscles or tendons which connect the muscle to the bone that it's trying to articulate. And a strain can either be a twisting, a pull, or in some cases a partial tear of a muscle. The last thing that a muscle wants is for it to be torn, because if the muscle is torn, it's done. It cannot function, and it cannot heal without surgical repair generally, because the muscle will contract unopposed and the two ends get too far apart. And so you need surgery to try and get it together, and it's just never the same again. So a tear is a very frightening injury for a muscle, especially for a sports athlete. It can happen usually with non-contact injury, but it's just a lot of strain. People running and trying to stop and plant, and they'll exert 3 to 4 times their body weight on those muscles and tendons. And if they haven't stretched correctly or they haven't prepared for that kind of exertion, then something's got to give. This is an example of the knee, and there's a big ligament here in the front that holds your quads. The kneecap's nestled in it, and it comes down here and attaches to the lower end of the front of your knee on what's called the tibial tuberosity. That's a very important one. It allows you to straighten your leg out. There's a ligament on either side, a rubber band, that holds these two bones together, and then the cruciate ligament is inside in the middle. So these are all really important, and the tendons of the quads muscles come down and hook onto the patella. So the question is, somebody falls or they're playing basketball and they hurt their knee. Well, what's going on? They fell. Did they break something? Did they sprain something? Did they strain something? And how do we figure that out? And I promise you, if you come see me on Saturday, I will be doing this all day long. And here's what we do. Our fellow Northern Americans to the north of the border in Ottawa years ago came up with this criteria called the Ottawa Knee Rules. And you can use this if you'd like. The Ottawa Knee Rules help us predict what's the likelihood that there's an injury that can be seen on an x-ray. It doesn't exclude an injury, but any injury, it excludes an x-ray or a broken bone. So it's kind of nice. Do I need to x-ray this or not? That's the question. Obviously, if the leg's not working at all, you're way beyond an x-ray. There's definitely something wrong. But if they're hobbling along, so the rules are, if you fail one of these 4 things, then you got to get an x-ray. Something's going on. So issue number 1, are you over the age of 55? Boom, automatically you fail. You old man, we just don't trust you anymore. The bones just aren't what they used to be. Sorry. If you can't walk, and this is really important. People will come into me all the time and say, I can't walk on it, it hurts so bad. And sometimes you kind of have to ask them and say, well, really, can you not walk, or you just don't want to because it really hurts? There's a difference. And usually you can kind of see them, they'll hold on to their buddy and they'll kind of walk like this. And I get it, you're not walking normal, but you're walking. And that's what this rule is. And then you just push on the kneecap. And if the kneecap doesn't hurt, and the outside, the fibula, is the outside of your knee, the lower part of your knee. If they don't have any pain, when you push right there, you're done. Could they have a sprain or a strain? Yeah, probably. But it's not broken and it's not torn to where they can't function. And so it really helps decide, do they need to spend a couple of hours and some money at an ER or an urgent care, or can they wrap it and ice it and move on? And guess what? Our Canadian friends did the same thing about the ankle. Said, this is what happens when you get into socialized medicine. Like, I'm so sick and tired of spending money on x-rays. Is there a way we can figure this out? And so they figured it out. And so what they said was, well, if you have pain on the outside edge of the back outside bump of your ankle, or the back inside bump of your ankle, or the top of your foot, or the outside edge of your foot, okay? The outside edge over here, if you have pain at any one of those 4 places, you need an x-ray. If you don't have pain in any one of those 4 places, I understand you're sore. I understand it hurts. And you were so close to winning the game, I know, but you don't need an x-ray. Yes?
Is that pain on palpation or just pain just set?
Pain on palpation. Generally, it's difficult for them to localize, and so the palpation is the key, because it'll help them localize. They're just like, dude, it hurts on the outside of my ankle. Okay. And it's kind of interesting because the study showed that the predictive value is on the posterior, the back side of the ankle bone, not the front side. So you actually have to push on that back side of the bump. If they hurt on the front side, no worries. Okay? So that's kind of fun. And it gets back to that same thing. They have to be able to bear weight. They may need to hold on to somebody, but they can kind of hobble along. They're okay. All right, so maybe they've decided that they don't want you to transport them, and they're kind of disgruntled that they lost the game, and what are we going to do now? Well, if they don't need an x-ray and they don't want to go, then you say, well, you probably ought to settle down. You're going to have to take a break for the day and let this heal, because you've probably injured the ligaments. So you can splint it, or if they desire transport, then you splint above and below the joint to stabilize that joint. And what do we carry on our rigs? The SAM splints are nice, but they're spendy. We just have the cardboard ones. Those work awesome. I'm going to show you a picture of one later. The cardboard ones are great. And push comes to shove, you can do an ACE bandage. That'll work just fine. And just provide them some stability. How many of you have heard of the acronym RICE? Memorize it, keep it. This will help you, help your kids, help your dad that's over the age of 55. This will get you out. Rest, ice, compression, and elevation. And then they need some ibuprofen. And that's just going to help nurse it along for a couple of days. It's really good. I use it all the time with patients. I even had one of them say, I already know that. I came all the way here to the ER and that's all you're going to tell me? And I'm like, well, that's the answer. I don't have any other answers. Dislocation. Remember that 2 bones are separated and that creates a joint. So they're supposed to be separated by a small amount, but if they're separated by a larger amount, that's not normal. And sometimes it can rip the ligaments, or sometimes it strains them and the joints fall out of position. It can happen from high impact activities or high stress activities. Football, basketball, ultimate frisbee. I see a lot of shoulders popped out from that. And then there's jumping. There's this place downtown, who shall remain nameless. I will be politically correct. I swear it's owned by orthopedists. But this place that shall remain nameless downtown frequently provides customers for me for this. All he was doing was jumping. It's kind of pointing the wrong way.
Yeah.
It's actually completely dislocated. His foot literally is sitting next to his leg. They're next to each other instead of on end.
That's dislocated, not broken.
Actually, it is correct. None of the bones were broken. It is a complete dislocation and complete total disruption of all of the ankle ligaments. He will have arthritis in just a few years, and he's only 22. So I take my kids to this place that shall remain nameless, and I watch from the sidelines and enjoy. So here's an example of how this looks on the leg. The tibia comes down, the fibula, and here's the top of the foot, and his foot literally was sitting next to his leg. Believe it or not, he was in zero pain. No pain whatsoever. But I came over and I started to look at it, and I reached my hand out, and even before I touched it, he started freaking out. No, 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 don't touch it, don't touch it, don't touch it. Obviously. So yeah, I had to put him to sleep because that was, it was not going to, it went well, but it would have been really, really painful. Have to pull on the foot, twist it to get it, it gets perched on something, twist it, pull, straighten it out, and then let it clunk back in. And then it sits there. It's actually really cathartic. It's very, it feels good. Well, obviously for me.
Take it back out a couple of times.
That's a little unethical. I draw the line. So I was going to say I'm probably this weekend in a couple of days going to be doing a lot of this at Hoop Fest, although this is not quite the Hoop Fest we're talking about. I guess it's this one. So here's another dislocation I took care of last year. So these are all the things that you shouldn't be doing. These are dangerous to your health. This lady was just going for a jog from her house, and she tripped. Now look carefully. Which finger is it? Initially, it looks like her index finger, but it's not. That's her ring finger. Ooh, that's going the wrong direction. See, here's the thumb. And that's the fourth finger.
Put her out and just yank. Fix it.
Actually, she was doing the same thing. She was like, don't touch it. And she had that really stern, she was 44. She had that really stern look. And she looked at her husband as if to say, back me up. Don't let anybody touch this. And then she looked at me with those eyes. Don't touch it. So what I did was I took a needle and I stuck it right here and injected in front of that and just put numbing medicine and just blocked the entire finger so she couldn't feel it all. And then I just walked up and just went, and she kind of cringed and she was like, that's it? You're the best doctor! I don't care what I've heard. So when we talk about treatment for dislocation, I've shown you some examples of people that came to me with the joint still dislocated. So obviously, it wasn't treated in the field. You saw that ankle that was splinted as it was because it wasn't in any pain. Did you notice what was written on that ankle? An X. And what was on that X? What does that X mean? A pulse, that's right. And so the key for a dislocation is to make sure that you have a pulse beyond the dislocation. And what's the other thing that you need to know? Sensation. Exactly, sensation. They may not be able to move it very well because it's dislocated, so it's kind of hard for it to function, but they should be able to feel it. Now, here's the key. In some of these joints, like this is a knee, sometimes it'll be dislocated, so this is a posterior dislocation. The artery for the knee, God figured out that we were going to do a lot of stupid stuff. And so He didn't put any blood vessels on the front. And he really didn't put it back here in the fleshy part. He tucked it way back here, right next to the bone, so that we couldn't bleed out. The problem is that if you do something really ultra stupid and dislocate the lower part of your leg, it stretches that blood vessel and the nerve runs right next to it. And you run the risk of compromising the blood flow. That is an emergency. And so here's an example. Sometimes the lower leg can get twisted or pulled sideways. In this case, the leg gets pushed backwards and it can disrupt the artery or stretch it. Most of the time it doesn't break it, but it'll stretch it so tight, like if you have a straw and you bend it off to the side, it clamps it down, so because it's tight, there's no blood flow. So the lower leg isn't getting blood flow and the nerve is getting trashed also. That's actually an emergency. And they may come to you and say, don't touch it, don't touch it. And if you can't honestly get a pulse, even the BLS, if you're a nice person, you'll wait for ALS to come and put an IV in and give them some medicine. But if ALS is 20 minutes out, then it's time to cowboy up and get her done. So, the key with this is that with these types of injuries, it's so easy to get distracted. Because all you're looking at is this finger, I guarantee it. So, you have to go back and say, like I asked this lady, I go, do you hurt anywhere else? And she gave me those evil eyes again. Like, are you insane? But I had to, do you have any pain here? Do you have any pain here in your wrist? And I had to go through that to make sure that she wasn't just focused on that finger, that there was another injury that we're missing. Okay? So make sure you evaluate the vascular pulses. And so here, you're not going to feel a pulse in the fingers, so how do you test for blood supply?
Capillary refill.
Yeah, capillary refill. Should be less than 2 seconds, and they should be able to feel it. Okay? And she was, as soon as I walked in the room, because if she was having difficulty, then I've had to do it before, and I just start talking to them, and and then usually I pull that trick, hey, what are you doing? And that gets there, they look away, and I just go, punk, pop it back in. Because you got to do it. So, like we've talked about, you can stabilize and transport if they're freaking out and saying, look, it doesn't hurt, just don't touch it. As long as the pulse is okay, the nerves are okay, and a soft one is the pain part. If it hurts, but if they're not in a lot of pain, then you can leave it. But if any one of these is true, they're missing a pulse, the nerve function is gone, or they're just in extreme amount of pain, and usually you see it like in car crashes where the femur's cracked. That's got to be horrible. Where the femur's going the wrong direction. I say, just kind of put it the general direction that God built it, and that's just going to help them feel it. It's going to hurt, but they'll feel better while they're transported. So, okay. This didn't come out so well on the slide. Can you tell what that is?
Something like a dislocation.
Yeah, it's a patellar dislocation. This is the kneecap, and it's off to the side. Anybody seen one of those? Uh-oh. Somebody's had personal experience with one?
Oh, yeah.
Oh, yeah. Sweet. So we can get you out doing some squats, and then you can demonstrate for us or something?
Yeah.
Okay. So usually what happens is, it looks like, I've never had it happen to me. It looks like it hurts. I can only imagine. It looks like it hurts, but the leg is kept bent, and they don't want to move it. And that's because the quads are being pulled off to the side and run down here. And the knee is popped up, so it can't, it's hard to get it back on top. And the answer is, I think the last one I had was about 2 years ago. And they're like, it was like a 12-year-old, and the dad was there. He's like, is he going to need surgery? What's going on? So I've got a hold of the leg, and I'm just talking to him, and I'm just slowly pulling on the leg, slowly just straightening it out. And then I just reach up and I just kind of go, well, let me take a look at your hips. And as I do that, I just kind of pull and push at the same time. And it popped right over and he goes, oh, it's better, Dad. And I said, you can go home now. And they're like, what? That's it? That's it. It's back to normal. Here's the number for the orthopedist.
Just like school.
So, what would you do with this? Would you stabilize or treat this? Yeah, look at the color of this. Does the color look okay? Yeah. So, I mean, I would do the same thing with you. I would check cap refill, but the color, as I walked through the room, I was like, it looks pretty good. And so I walked up, can you feel me touching you? Yeah, okay, good. What about this? What's this?
Shoulder dislocation.
Okay, now the big test is which shoulder's out.
Is the right shoulder.
Okay? We call it the empty glenoid sign. So see how the shoulder just kind of naturally just rounds off over there off to the side, the deltoid, the biceps kind of come up and all that kind of stuff. And here it just drops right off because it's out of its socket, and so it's anteriorly and usually inferior displaced, and so you just get this abrupt. And they usually hold their arm like this. That's the most comfortable position. And so in this one, unless you know how to maneuver it, you just anchor them to their body like this. You can wrap them if you want, or usually they'll hold it. They'll bring their other arm in and say, don't touch me. And that's fine. Actually, the place to test if they're in neurologic danger is actually right here. And that area is called the regimental patch area. And it has to go back to way back in the military days. When the military guys, they had the patch of their regiment, like Big Red 1 or whatever, right there on their shirt sleeves, where you guys have your patches. The nerve, when one of the nerves, when the shoulder's dislocated, the nerve that provides the sensation to this outside part of the shoulder gets compressed and you lose sensation. So I always walk up to them, can you feel me? Yeah, what are you doing? Okay. What's this? Anybody seen one of those? They're not very common, but they're pretty uncomfortable. And I've tried to reduce them without sedation, and it generally doesn't go well. So I usually have to put them to sleep. But you can see the ulna looks like, it's called the semilunar notch, looks like a moon. And so you can see, usually it's perched on this little lip right here behind, and it's really hard because their muscles are spasming and they're all tense. But really all you do is you reverse the process. You push down on the forearm and then pull out and just move that hook back in, and it goes in usually really well. It's kind of cool. All right, so same question. If you were in the field, would you stabilize it or treat it? Yeah. He actually had he had good blood flow, but he was starting to get tingly in the toes. So I knew that I had to get my game on and get some medicine in him, because this would be brutal in the field. He would be yelling and screaming and kicking, and see, this shoe's still on. He'd try to kick you. So. What's that?
Stabilizing above and below that joint, right? Is that going to flop around where it's at? Right?
You know, that's a really good point, and that's what I had advised before. There is so much spasming of the muscles with everything, because all these ligaments that belong down here are completely disrupted. It's actually it's hard to relocate it without medicine, because it's so spasmed and tight, it locks it in. So you'd think that it'd flop. He can kind of wiggle his toes, but the foot is actually kind of anchored there. It's kind of interesting how it ends up. Good question.
It's probably difficult to get a shoe off without moving it too much to...
Yeah, and usually that pretty chore falls on your square shoulders and not mine.
He was at that trampoline place, so he wasn't wearing shoes.
Oh yeah, good call. Except for that one.
Let's put that on a transport.
All right, so again, with dislocation, if you make the decision to stabilize, splint them, put them in a position of comfort, and just protect them against movement. So kind of like you were saying, if it looks like it's going to wobble while you put them on the gurney and AMR is going over our smooth roads over to the hospital, then see if you can, MacGyver it. Just figure out some way to just kind of bulky and stabilize it, and that's cool. Whatever you can do to help the patient. And really the treatment is just to put it into what's called the anatomical position. Believe it or not, that's a name. And this is a picture of the anatomical position. If you go to Japan, you study anatomy with the same position. This is the front, this is the back. But the arms are positioned that way with the palms facing forward. The feet are down. Actually, the toes are kind of plantar flex. The toes are pointed down. The head's in the upright position. And that's how we identify the front of the arm. So if you came to me and said, yeah, I've got this cut on the front of my arm, I'd say, no, that's actually the back of your arm. Because anatomical position, so that we all position the body in the same way around the world. So that's the anatomical position. So like you would do, if you needed to use a hair traction or a Sager, again, it's just like, well, what position did God put us in? Is there a way that I can try and get it back in the same ballpark? And that's what we do with femurs, and you guys are all trained on that. We carry the Sagers, right? I saw one hair traction from outside the county recently. Almost everybody's doing these now. Yeah. Everybody comfortable with these? That's good, because these are really helpful, especially on femurs, because those are so unstable. Okay, a tendon rupture. Oh man. If the tendon that connects the muscle to the bone is completely separated, then you have complete loss of function. It can't do anything. And you lose normal shape and position of the joint. So I'll give you an example. This is called a quads rupture. And so what happens here is that the quads tendon, before it gets to the patella, gets ripped. And so you can see the kneecap is actually a little further down because the ligament has spasmed, and you push there and there's a hole. And if you reach down and feel your leg, there's no hole right now. There's a really, really, really strong tendon right there. And I've done this before where I just walk up and push, and it's just like, oh, that was a little further than I anticipated. And you make the diagnosis. Okay? Here's another one. This is called patellar rise. And we usually see it in weightlifters. And that's why the weightlifters have their beneath their knees taped. Because they're doing deadlifts or squats, and they'll blow out the lower part of this tendon. Just completely blow it. And all of a sudden, the patella is sitting up literally in the middle of their thigh. They've pulled so hard, that muscle is pulling so hard, basically to straighten the knees out, it just rips this off right there. And so what they're doing is they're taping that to try and keep that ligament as close to the bone as possible, so as the knee is straightening out, it's not going to pivot side to side and run the risk of, it changes the vector of the forces. So that's why they'll tape them like that. Because this is a career-ending injury. I mean, the orthopedist can put that back together, but you're never going to lift like this again, because you just can't make it back the way God made it. So that is a career-ending injury. So basically, they'll sit there and they can't straighten their leg out. You say, straighten your leg out, and they're like, I'm doing it. And it's not moving, and you're done. The tendon's completely gone. Here's one that we've seen recently. This has happened a lot, but this is one of the more well-known ones with Kobe. He popped his Achilles. And remarkably, it's a long surgery and it's a long healing process. But remarkably, a lot of them can get back and get into sports again. I had a guy, he was 42 years old. He was a principal at an elementary school. And so it was lunchtime, and he was out on the playground with his students, and a couple of kids were doing jump rope. They were doing the double Dutch thingamabob. I'm a little curious how you know that, but I'll let that go for now.
He's good.
Okay, all right. Whatever you say. So they were doing this, and he's like, "Yeah, I'm going to do it with my kids." And so he jumped in and took like 2 hops and just collapsed. And the kids, he came in and he was like, they were all laughing at me. Big black guy. And so he's like, I couldn't stand up. And I asked the same question. Okay, I know it hurts, but was it just too painful for you to stand? Or you just really couldn't stand? He goes, I couldn't stand. And so I reached over and felt behind his ankle, and I was like, oh yeah, no, you can't stand. And this is what it looks like.
Oh, nice.
You see how there's complete loss of definition of that tendon. Complete loss. This is from all the swelling, but what happens is, picture a rope. Have you guys ever pulled some rope, I don't know, between your engines, and you pull it to the point where it breaks, and that rope snaps and the ends just go psh, just fray like that? This Achilles tendon just splays like that, wide open on both sides, and within there's a lot of blood in there. 5-10 minutes, it's just one big mush. And so what happens is, so what we did is, this is looking straight up and down. The muscles on the back of the calf are actually stronger than the muscles on the front of the calf. And because that's the case, when you relax, your foot is actually pointing down. It's not in the neutral position because the Achilles tendon is so tight. Because when we walk and take a step, you actually have to use your calf and push off with your Achilles tendon. So that tendon is strung tight. And so you just look straight up and down, and it's got nothing. It's straight. There's nothing, there's no tension whatsoever. It's kind of interesting to make the diagnosis. All right. So this happened to me last fall. I was working a shift, and I was supposed to get off at 5. I didn't get out till 6, and my son was playing on the high school basketball team. So I jumped in my car and drove out to the high school gym, and I got out, and it was the game had already started, and so I kind of snuck in around the edge of the gym and around the edge of the court and sat down next to my wife. I'd been there 5 minutes, and of course the only seats that are available are the ones on the floor, or on the bottom in this, at least for us in this gym. And so we're watching this game, and it's a fast-paced game. They're going back and forth, back and forth. Somebody goes up, comes down. The ball didn't go in, so it gets recovered, and the whole game moves to the end of the field. And my eye catches something, and there's a player on the ground. And I was like, oh, he just landed funny. And I see, and everyone else is watching the game. I'm looking at this player on the ground, and his lower leg is like this. And the referees, the whole thing had moved down there, and I was like, that guy's not going to get up. And if somebody doesn't make a basket, the whole team's going to come down and crash into him. And I wasn't even thinking. I just jumped up and ran onto the court. And my wife's like, what are you? And then she looked to see where I was going, and she screamed, which then made all the other women look, who also screamed. And so I ran up, and I was holding his leg, and I could tell he couldn't quite see. He was holding his knee. And he was like, oh, something's wrong, it's hurting, it's hurting, it's hurting. And I was holding his leg, and so he had his shoes on, and so I'm yelling at the ref, time out, time out. And so I just started, I was like, can you feel me? And he goes, I can't feel my foot. And I was like, okay. Well, how long have you been playing? Boom! And just straightened it out right there. And then just held it. And so I'm holding it, and he actually didn't even flinch because I think there was just so much adrenaline. And you've seen this, within a couple of minutes they start getting pale, and they're just kind of going into emotional shock. And I'm sitting there holding this, like this, right next to my body. I won't let him move. And then finally a couple of coaches come up. They're like, "What's wrong? Let's see if he can walk it off." And I was like, "He can't walk." No, let's try. He can't walk. And then one of the sports trainers came up and said, "Hey, all right, I'll take over." And I was like, "No, I'm going to hold this." No, let me see what's going on. What part of the ankle's hurting you? And I was like, "He broke his leg." And she kind of looked at it and she goes, "Nah, I don't think so." And so I was trying to be nice, but everyone's like, "Let's just get him up and then we can continue the game." And so finally I was like, "Look, I'm an ER doctor. He broke his leg. Get a stretcher." "Who are you?" "Just get a stretcher." And we got him off to the hospital, and sure enough, he had to have surgery and all that kind of stuff. So it was kind of interesting, and so here it was just an obvious fracture, but I made that decision right then and there to just kind of straighten it out, and I got it early enough that he didn't even really notice it. And I talked to him a couple months later after a game, because he was on the sideline. I said, "Do you remember me?" And he goes, "Yeah, I do. You were down with me when I fell." And I was like, "Yeah." I said, "So do you remember anything else that was going on?" "No, it just hurt, and I just had no idea what was going on." I was like, "Cool. All right. That's good. I'm good with that." So fractures can happen when there's a break in the bone, and usually it's just a one-time event. And I think he thinks what happened was he was just driving, planted, and was kind of changing angle, and his leg just gave out. I mean, what are the odds? It's like a 16-year-old kid. They should have bones of steel. There are other injuries where they're repeated stress injuries where the same thing happens over and over again and you get a crack in them. See that a lot in the spine. Really, the ones that are significant for you, we define them as simple or closed, or compound and open. Open meaning you can see bones sticking out through the skin. That's bad. Okay? All fractures are emergencies. They need to be evaluated whether they feel better or not. And usually you'll be able to figure it out because it's not in the joint, it's where there's not a joint and now there's a bend that doesn't belong there. And obviously if it's an open wound, there's now something sticking out of the skin, so that's not normal, and something's broken. And so the key here is to stabilize and prevent any load bearing of that bone and to go a joint above and a joint below. So maybe you've seen this before. This was my kid that I took care of years ago. He was 8 years old. See his little Spider-Man shirt? How many of you have... Some of us are too old, but some of you are still young. How many of you have ever had Heelys? That's the right answer. He had Heelys. You know those little shoes with the wheels built in the heels? So he'd run and then kind of skate, and small rock is what he hit. See, only you got that. You guys are all, and you got it too? All right, that's good. So he hit a small rock and the wheel stopped and it just threw him forward and he landed on his hands. And so this is his shoulder, this is his elbow, this is his wrist. So he's got an extra bend. Actually, he's got 2 extra bends. Yeah. So he was doing the same thing. He was crying, I think, because he was scared. But my resident was there, and he's like, "Don't touch it, don't touch it." And he actually was compromised neurologically, and the OR was delayed. So I had to give him medicine and just straighten that out. And then the blood flow pinked up, and it started working again. So again, just like a dislocation, don't be distracted by the injury. Make sure there isn't anything else going on. "Oh yeah, my neck hurts and I've got tingling in my arms." Let's not miss that. And make sure you evaluate for pulses and neurologic sensation beyond the fracture, the obvious fracture. And so again, the parallel is the same for dislocation. If pulses, nerves, and pain are okay, then you can stabilize, and if you're missing one of those, you really need to treat it. And if it's an open wound, cover it with a dressing. It's already contaminated, and I'm going to give antibiotics, but the more crap that gets in there, it really is hard to... They have a power gun with a suction hook to it that's like a power washer in the operating room. And it does a good job, but if it's a really, really dirty wound, it's hard to get all that stuff out. And if you get a bone infection, it just doesn't go well. So do what you can to try and cover it up. So rapid transport. The indications are if there's limb-threatening condition, despite your best efforts, they have neurologic compromise or no blood flow, they need to go really fast. Or obviously if there's a life-threatening condition such as a concussion, obviously a code arrest or brain bleed or cardiovascular shock, that increases the urgency of transport. So, yes?
If we have pulse in the lower extremities as well as sensation, but we still have a compound femur fracture, do we want to pull traction on that, or do we want to just...
Yeah, you know what's going to happen? I think in the long... I'm glad you brought that up. In the long term, the patient's going to do better if you put it in traction. What's going to happen is those fragments, the femur, it actually looks like a... If we got into it, you would see it looks like a knife. It kind of... Rarely will it break just in half. It usually breaks in a shard with sharp edges. And then all the quads and the hams, because the bone is injured, are just constantly contracting and spasming, and it's pulling those knife blades in every minute. And it's basically just spearing the muscle. And so it's kind of spasming to protect it so it doesn't move very much, but in the process you run the risk of more damage because the artery and the nerve actually wrap around the bone and then go behind the knee. So in that situation it would be better to put him in a splint and stabilize it and elongate it. Yeah,
Okay.
Good question. Yes?
Just to clarify, you don't want us to put the bone back into them, right? Just stabilize it, make sure it doesn't contract any further. You don't want that open bone going back into the body, right?
You know, there is argument in the literature and some argument among orthopedists that say, I'm going to have to get in there and wash it out. If it's contaminated, here's my bottom line. If it's contaminated, it's got a lot of dirt, I'd leave it out, dress it, and then stabilize it so it doesn't shorten anymore. If it just looks like, obviously it's contaminated, but the bone is just sticking out, he didn't end up in the dirt or something like that, you can stretch him out and then close it and just say this is... If I know there's a break and I see there's a cut there, that happens, is that the bone will puncture through, and then in the process of extracting or whatever, it'll reduce on its own. So when he comes to me and I see a cut there, I'm going to call it open. So we're okay. So if it's not grossly contaminated, I think that's appropriate, is where we are currently. Good question. Thank you for asking. So we'll finish with water activities. A seemingly forgiving environment. It looks so soft and so nice. Until you're going like 50 miles an hour and you crash into somebody else that's going 50 miles an hour. Or you do a face plant at whatever speed he's going. It's not quite as fun. That looks like he's having fun, but I assure you in another second he was not. And of course some days you can have a really bad day. And believe it or not, even here in little old Spokane, we can have problems with water activities. Right here in River City. That was a reference to a movie. Again, you guys are all too young to know what movie that was. Who said that? Sweet. Nicely done. So, this is our fair river here. And a couple of days ago, I had the unfortunate experience of having to take care of somebody. Did you hear about this on the news? So I was on trauma duty that afternoon, and they brought him in to me. From what witnesses say, they were out playing in the water. He was not wearing a vest, and they turned around, they couldn't find him, and they looked and looked, and they activated 911. The divers came out, they found him submerged, and brought him out. But he was unresponsive. They started to do CPR, and he was cold. And they did a quick look, and he had some disorganized electrical activity in his heart. So they decided that because he was young, that they would proceed with ACLS, which is fine. And because the caveat of he was cold, and so what's the motto? You're not dead until you are warm and dead. Exactly. So they intubated him in the field. And hopefully you remember my cold weather lecture, because they gave 6 rounds of epi. And I wonder why he was in VF. They gave 6 rounds of epi and a couple amps of bicarb, and still weren't getting anything significant back. Never had a pulse. Never had spontaneous respiratory movement. And they came in just like, I don't know if you've seen it, one guy's standing on the edge of the gurney doing compressions while they're wheeling it down the hall. And they come into the trauma bay. And the other thing is, they said after they started bagging him, they said it was getting hard to bag him. And so they were concerned that maybe he had punctured his lungs. So they decompressed his lungs on both sides. They needled him on both sides. And then they said it got hard to bag him again, so they decompressed him again here, which was interesting. So they'd given ACLS, they had shocked him twice and didn't have any results. And so I get him on my table. My guys are doing CPR. He felt cold. I get a temp. He's 87. That's too cold. So I'm like, okay, well, what am I going to do? So we continue CPR, and he said, we're not doing any more meds. They're not going to work for now. So we have a level 1 infuser. It can run 1 liter per minute through an 18-gauge IV. So in 5 minutes, I can replace your blood volume. Well, I can put blood in it too. And what that level 1 infuser does is it'll take saline, and it has a heater in it. And so it will heat it up to 106 degrees. So you're piping hot water into the veins. So that's one way to try and reheat them. And then we put one of these bear huggers, some blankets and stuff to try and externally warm them. 30 minutes, every 2 minutes, just like I was teaching you, every 2 minutes, I'm yelling out, all right, we're going to do a pulse check, and we're going to swap out people. Who's my next person in line? And I was lining people up, because every 2 minutes, and they were dripping sweat. And so we do a pulse check, no pulse check, jump right back in doing compressions. And I was standing there. All right, how hot is he now? So I kind of gave up from the sense that this was going to take too long. So I did a procedure where I used a scalpel and I opened up his abdomen. And I put a catheter inside his abdomen, and I hooked up the level 1 infuser. And I ran 3 liters of hot saline into his abdominal cavity. So basically, I'm trying to warm him from the inside out. And in 15 minutes, I got him to 94 degrees. It was awesome. And so then I resumed ACLS and started using meds. And I had ultrasound, and actually I got him back. And I got a really good heartbeat. And I had to shock him once, and then I got him into a rate of 38. And I will admit, at this point in time, he had been down approximately 90, 95 minutes. And so I was actually really surprised. The first thing I got was a bradycardic rhythm, and I was like, And then I thought I could feel a pulse, so then I got the ultrasound, and his heart was beating pretty strong, and I was like, whoa. Now what do I do? So I called the ICU and I said, I think you better find me a bed. And I measured the pH of his blood, and the pH was 6.77. That's really bad. That's really acidotic. The channels in the body and the proteins in the blood don't work very well. So I started giving him bicarbonate to try and bring his pH up. and 10 minutes later I lost a pulse. So he went into PEA. So I had a rhythm, but I had no pulse. And so I put him on 3 different pressors, medicines to try and squeeze his blood pressure up and keep him alive. And I could never get a pulse back. And then I re-examined him, and he was always fixed. I could never get any neurologic response. And I was like, it was 2 hours and 2 minutes that I was at the bedside. So he was down probably 2.5 hours, and finally gave up. But he was warm, and he died. So this was just a couple days ago. Kind of unfortunate, even in fair weather. Just remember that, here it was in Spokane. It wasn't winter, and yet he was hypothermic because the water temperature was cooler than the body. Don't forget that in water situations like this, there's always the risk for blunt trauma. I had him in a seat collar because I have no idea, nobody has any idea what happened to him. He could have been swimming underwater and went headlong into a rock and, did something to his neck and knocked himself out. In other situations, you could be on the lake, get hit by a boat, somebody's diving and they dive in shallow water and they could have some kind of blunt trauma, either the neck, the head, the chest. So unless this was a witnessed event, you should really strongly consider full spinal precautions because it'll be worth it. And remember, the situation in this case, the reason this guy coded was because he didn't have any oxygen. And that's evidenced by the fact that I got his heart back. He was 19. He wasn't having a heart attack. He didn't need epinephrine. He didn't need me to shock him. He just needed oxygen so his heart could work. And so really in a drowning situation, really this is where the priorities change, where we go back to the old school and we say airway, breathing, circulation. This is one of the exceptions where the last 5 years I've been preaching it into your heads. Circulation first, CPR, compressions first. This is the exception because he needed air. If you don't feel a pulse, then you just do continuous CPR and establish an airway, and that's how we're going to get these people back in drowning incidents and try and rewarm them, and get them to a trauma center. The last thing is concussion and traumatic brain injury, and here's an example of it. As somebody threw a rock, what it does is it causes rapid acceleration and deceleration. So the rock is going to hit the front and thump the front of the brain, but then the brain, there's a little bit of wiggle room inside the skull, and the brain is going to get pushed back, and the back of the brain is going to tap the back of the skull. And that's called a contre-coup. It's French for other side, literally. And so we have the coup and the contre-coup injury, and basically you're just rattling the brain inside the skull, and it doesn't like it. And so the mechanism is it can cause direct injury to the cells themselves. It can cause injury to the blood-brain barrier so things don't move across very well. It can cause damage to the blood vessel that leaks. And then just like if I walked up and I punched you in your arm, a little while later you'd have some swelling from that injury. Same thing happens. The brain, parts of the brain tend to swell, and the brain does not like that. It does not function well with swelling. This is an example of 2 different types of bleeding. Don't worry about the names. One's called an epidural hematoma and one's called a subdural hematoma. It has to do with how and where they form. But suffice it to say, bleeding in the brain cavity is not a good thing. When there's bleeding outside the brain on one side, it puts pressure on that side of the brain. And when that side of the brain has pressure on it, it puts pressure on the nerve that goes to the eye. And when you compress the eye nerve, it makes the pupil dilate. So one of the things that I want you to know and remember is that if you look at somebody different and the pupils are, and they've potentially had some kind of traumatic exposure that could have caused some injury to the head, that may be the sign that they've got really, really bad brain injury and they need fast transport. So a blown pupil suggests herniation of the brain. There's another injury called DAI, diffuse axonal injury. The brain has two layers, an outer dense layer and an inner less dense area. What happens is when the brain, if you crash your car, the brain instantly stops. Sometimes it happens from swelling, sometimes it happens from the acceleration, deceleration injuries. And I'll give you an example, and one of the things that we're concerned about is concussions. And the question is a concussion the beginning of that rattling of the brain? And it's manifested clinically by confusion. The patient doesn't remember where they're at or who they are, or they don't remember, what day it is or what location there is, or worst case, they have loss of consciousness. That's a concussion. And so people will say, well, how long until my loved one gets back to normal? And it's really, really hard because everybody heals a little differently and there's so many variables. How hard did they get hit? Have they been hit before? How old is the person? Are they on any medications? And then is it just pure luck? How is it going to end up? And so I tell people, a month? A few days? I don't know. And so it's very frustrating for families initially because the patient doesn't even know. They don't know what's going on. They're confused. And so after this concussion, it can be simple to do. It can be simple. It can be difficult to do even simple math. Balance a checkbook. To remember normal tasks. They'll sit there. I've had people come in and say, I know this is a toothbrush, but I can't remember how it works. That sucks. And short-term memory loss. They'll remember, hey, didn't we just get married? And the spouse is like, yeah, like 19 years ago. Which, of course, rips the family apart. They're just like, oh my gosh. And understandably so. So ultimately, most people with mild concussions, they will restore to normal. They may not remember the incident that caused the concussion, but most people will come back to normal if they haven't had a big concussion in the past. The brain will heal from some smaller one or two incidents, but if you have multiple ones, it doesn't do well. So have you heard of second impact syndrome? I'm going to end with this.
Yep.
I'm going to end with it because this was my case. Perhaps you remember this if you lived here back in 2009. The 17-year-old was playing football for a local high school team. He was actually playing out in Wenatchee. And he was in the second quarter of the football game in September and took a helmet-to-helmet hit, and it knocked him out. And he was down for probably, they estimate, 10-15 seconds, and then got back up and was kind of stunned. They took him off the field, put him on the bench. Halftime went through, third quarter. The guy jumped up, come on, coach, put me back in the game, put me back in the game. Come on, coach, put me back in the game. Seemed like he was doing okay. So he jumped back on the field, second play. I think he was a linebacker. He was rolling out and just took a wrong hit. Took a wrong hit and immediately went unresponsive. He didn't get up. Somebody rushed out on the field and noticed that he didn't have a pulse and lifted up his pads and started doing compressions. And because they were out in Wenatchee, they launched MedStar, the EMS unit that was there launched MedStar, who was on the scene probably within 10 minutes from where they were at. They were able to get there. And they actually got a pulse back. They intubated him and flew him into me. And by the time he arrived to me at the trauma center, his blood pressure, his heart rate, everything, stone cold normal. Took all of his pads off, took his helmet off. I couldn't find any bruises. I couldn't find any scratches. I couldn't find, I mean, sweaty, but I couldn't find anything else. I CT'd his brain. There was no bleeding whatsoever. The brain looked picture perfect. And what had happened was he had second impact syndrome. And we don't fully understand the mechanism. We just know that it is. And so I share this with you because this family was torn apart, and we've since in Spokane County, the public schools have gotten together and said, we need to put some things in place. The hard part is at that time, even, well gee, this was 2009, we didn't have a lot of research on this. We didn't have a lot of guidance to give them as to what to do. Now, most of the high schools, when the players start in the fall, they sit them down, they make them take a simple math test. 8 plus 7, 12 minus 4. And they make them do the test, they time them, how long they do the test, and they grade them. It's like 5th grade math. And they take that specific test and they file it away. If the player gets a concussion, he's pulled out from the game, and he's out for a week, instantly. And that's now national guidelines. Can't go back in for a week. You can't play practice. You can't do any practice. You're done for a week. And then at the end of the week, they'll sit you down with that same test and make you take the same test and time you. And if you don't get within the same time and the same number of, hopefully you get 100%. If you don't get 100% and you don't get the same time, you're grounded for another week. And then they just do the test over and over again. And that's the best thing we got right now, to try and figure out, is he out of the woods? Because we know that the answer is that the brain will be okay, or it's okay to go back in the game once the brain is recovered. And the question is, when is it recovered? And obviously the coach thought that the player had recovered. Put me back in the game, coach. He's standing up, he's moving everything, he's excited. He called me coach, he knew what was going on. But he wasn't okay.
With the second impact, doesn't the brain swell and push itself right up against the skull, so the next impact, there's no wiggle room, it's just basically whatever impact is transferred?
Yeah, so the question is, with the first impact, was there swelling with the brain? And so when you take a second impact, there's no more room, no more wiggle room. We think that's one of the mechanisms. Again, it's hard to study it because we don't have a lot out there. We don't have a lot of scans. Really need an MRI to figure that out. A CT scan's not good enough. So they're trying to do studies on it. But yeah, that's one of the leading things that we think. And so the cognitive tests are now the way to figure out when you can put it back in. The problem is we don't have a way to treat it. So these concussions, and really the best thing is to just prevent it and just say, look, we are not going to risk it at all. And every fall I see football players from Spokane County, guaranteed, sometime during my shifts. And the parents are sitting there, and I'll tell them, I say, ultimately it's up to you. But you just need to understand what's at stake. And I know your son is on track to be all state, but is it worth it? Well, what are the odds? Really? You really want to roll the dice on that one? So hopefully, my point to you is that hopefully you will spread the word in the community and educate other people, because this is tragic. It tears families, it tears schools apart, and it can be prevented if we're just careful about it. And most of the sports trainers now are up to speed on it. So we've talked about sprains and strains. We've talked about a variety of different joints and injuries, about ruptures, dislocations, fractures, concussions. So, question 1. Let's see how well you did. Which of these is not evaluated as part of the Ottawa knee rules to trigger if an X-ray is needed?
A.
Correct. A is not part of the decision rule. Which of the following is not an indication to reduce a joint in the field?
B.
How about Bravo? No function. So no pulse, you need to reduce. No sensation, you need to reduce. You can reduce if they're in extreme pain, but function, if it doesn't work, it's okay. Don't worry about it. We'll fix it later. Which direction is the hand facing in the anatomical position? Thumbs up. Palm of the hand facing forward. C. Which of the following is not part of the Ottawa ankle rules for evaluation? The outside ankle bone, the inside ankle bone, the outside edge of the foot, or the heel? Right, we don't care about the heel. It's really hard to break a heel. The only time I've seen somebody break their heel is when they've fallen like 2 stories and they land on their feet and they break their heels. How long must a player be kept off the field after a significant concussion with loss of consciousness? D, 1 week. Very good. All right, if you have your OTEP forms with you, it will speed us up so I can get you out of here. If you find the trauma section, believe me, you want this, find the trauma section, and please just write sports injuries, and then I'll just sign.